Good afternoon. We did our PET capstone research on hydration effects of SUVs of non-small cell lung carcinoma.
In this presentation, the audience will be able to recognize the capability of positron emission tomography, computed tomography, as an imaging modality on oncological studies, analyze multiple literature reviews comparing the usefulness of the standard hydration protocol, calculate standard uptake values, and identify the metabolic properties of fluorine-18 fluorodeoxyglucose, also known as F18-FDG.
F18-FDG PET-CT is a diagnostic imaging modality that is utilized in the detection, staging, and treatment of oncology patients. It combines positron emission tomography and computed tomography, and that combines metabolic and anatomical information that is acquired by using the PET-CT device. The most common radiopharmaceutical used in this is the fluorine F18 fluoroxydeglucose, known as F18-FDG. F18-FDG is a glucose analog, and it binds specifically to active inflammatory tumor cells or malignant cells. Standard uptake values are quantitative assessment measures that demonstrate how much activity an organ takes up. This numerical data was essential in our research as they were used to retrospectively compare each patient. So these scholarly articles prompted us to do our research that I'm about to review. Our research to compare pre-imaging fluid consumption effects on standard uptake values in the F18-FDG positron emission tomography, computed tomography on non-small cell lung carcinoma patients. So lung cancer is the #1 cause of cancer deaths, and 80 to 85% of lung cancers are termed non-small cell lung carcinomas. And in this research article by Serino, Roberto, and Giovanella, they used 4 different hydration protocols to assess the quality of F18-FDG images. Out of 120 patients undergoing the PET-CT oncological follow-ups, they were divided into 4 different groups with 4 different hydration protocols. Group A received a 500 milliliter bottle of water and was told to drink it freely. Group B was given a parenteral infusion of 500 milliliters 5 minutes after the F18-FDG was injected. Group C was given a 500 milliliter bottle of water and was told to drink it all at once. And Group D received a parenteral infusion of 250 milliliters 30 minutes after the tracer injection. This research was based off the idea that different hydration protocols were affected by 3 main variables. That is the volume of liquid, the method, whether it's oral or parenteral, and the timing, and the use of diuretics. The results show that delayed hydration did not significantly modify the distribution to target to non-target ratio. Diuretics decreased FDG uptake in urinary tract, but not improved the SUV max in the bladder. Insufficient hydration increased the SUV max in kidney and the bladder. All in all, in this research, the controlled hydration of 250 milliliters reduces background activity and increases the background contrast. Parenteral hydration did not significantly improve results and caused patient discomfort, and so did the use of diuretics that they used, so it's not ideal. I wouldn't change giving them a bottle of water or infusing it on them. In 2008, Khalif and colleagues published an article in the Journal of Hematology and Oncology entitled it "The Relationship Between Nodule Size and 18-FDG PET SUV for Malignant and Benign Pulmonary Nodules." This research tested that SUV cutoff of a 2.5 or greater to differentiate between benign and malignant nodules. 173 patients were involved in this research, and they were also divided into 4 groups based on their nodule size. Statistical analysis of the SUV max determined that the cutoff SUV max value was useful in differentiating between malignant and benign tumors for the larger nodules, but were not significant in differentiating them for smaller nodules. When using an SUV max, there's a risk of losing specificity and accuracy, and that was clearly present in this study. Small nodules tend to have lower SUVs than larger nodules, therefore an SUV max was not sufficient. In 2011, an article published used 37 carcinoma patients that used both SUV max and MTV, which is metabolic tumor volume. The research predicted short outcome when using chemoradiotherapy. They used 37 patients with advanced non-small lung carcinoma. MTV and SUV max were calculated for each patient. These two semi-quantitative assessments were evaluated to differentiate their lesions. In this specific research, determined that SUV max reflected the maximum intensity of activity in a designated tumor, but did not show distribution in that specific tumor. MTV is reflective for the entire tumor mass activity, and this study proved that both SUV max and MTV can differentiate responding patients from non-responding patients.
For our research, we retrospectively reviewed 26 patients' charts that received F18 fluorodeoxyglucose (FDG) imaging for non-small cell lung carcinoma at Allegheny General Hospital from July 2016 through October 2016. Our patient population was chosen due to the high volume of lung cancer patients that come through AGH. Our patient groups were broken up into 13 males and 13 females. Prior to the scheduled scan, each patient received a home phone call reminding them of the restrictions implemented by AGH, as well as a reminder for patients to drink up to 60 ounces of water. Upon arrival to the department, standard protocol was followed. Blood glucose was taken to ensure the patient was within safe limits. The PET technologist explained the procedure to the patient, and a pregnancy status of each patient was established. Each patient was asked how many bottles of water they consumed prior to their arrival and were categorized into the following categories. We had 3 categories: less than 48 ounces, 48 ounces to 80 ounces, and greater than 80 ounces. After the injection of F18 FDG, patients were taken to a serene environment without any outside stimulus for 60 minutes. 60 minutes post-injection, each patient was asked to void prior to the procedure. Patient imaging was acquired with the Siemens Biograph PET-CT, where each patient was imaged supine from the skull base to the mid-thigh. Our calculations, dose administered to the patient was calculated by the following. We took the measured activity prior to the injection, subtracted from the measured activity after the injection, which we got our overall corrected dose administered. Our standard uptake values were calculated with the following equation. The MIM, we used the MIM 5.63. It was already computer categorized to get our equations. Once imaging was completed, regions of interest were retrospectively drawn around the following: the left ventricle close to the lateral wall, around the central right lobe of the liver, on the middle of the right lung, on the right upper thigh, and middle of the bladder. Following this, the standard uptake values of each RI was recorded. After each region of interest was drawn, we compared the standard uptake values of each individual organ drawn independently. Once this was established, each organ standard uptake values were compared. It was determined whether or not the amount of water consumed decreased or increased based on the uptake of the organ. And now Elizabeth will present our results in a table form.
This is just a comprised table that showed our 26 different patients, their age, sex, height, weight, their BMI, their blood glucose. Our average age was 63.7. The average dose administered to a patient was 12.3 millicuries, and the average time the patient was imaged after being injected was 74.38 minutes. We had 7 patients drink less than 48 ounces, 11 between 48 and 80, 8 patients drank more than 80 ounces, and generally women had higher BMIs. Due to time restrictions, we're going to show you the graphs that we made so that I have time to talk about them so that we're not out of here. As you look at the slides, so the blue line is patients that drank less than 48, orange is in between 40 and 80 ounces, and then higher than 80. And this is for the heart, the lung, the liver, the bladder, the fat, and the thigh. So based on the data that we collected, the following results were drawn. Hydration does not affect the SUV of liver patients. The SUVs were not dependent on the water consumed. The bladder is the one region that SUVs, hydration reduced the SUVs in the bladder. SUVs in the lung were not strong enough to make a correlation amount of water consumed. They were all over the place on the graphs. There is also no correlation with increasing hydration to decrease the SUV of the heart. All of them were in proximity except for 3 outliers. They skewed the data for patients who drank 80 ounces. Their SUVs were a lot higher when we predicted that they probably would have been lower. The thigh presents similar data to the liver, that hydration did not increase or decrease in the thigh. So our finding that hydration does not reduce the SUV of the bladder, or does reduce the SUV of the bladder, but does not reduce the SUV of the lung, liver, heart, thigh, which correlates with previous studies. We compared them back to our researches, saying that we agreed with some of them, but disagreed that it was not. Our results correlated with other people's research and the fact that we decreased bladder, but we didn't decrease any other organ, and specifically we looked at the lung, and that correlated with what other researchers have done because we can't decrease something. We concluded though if you decrease an SUV bladder or SUV of the bladder, it might have the FDG would have more of an uptake in the lungs, which would then cause a better picture, but clinically we couldn't say.
Our overall conclusion, for time's sake, we would choose a different patient population. Many of our patients had underlying conditions that could have skewed our data. We would have chosen a smaller range for the, we had 60 and under for the amount of water bottle, or amount of fluid that a patient has drank. We would have more of a precise group, basically, and we really can't go off of what people say. They could have lied, so that might have skewed our data a little bit and also had an effect on our overall results.
Shock value improvements, I talked about those. This research would not have been feasible without our professors, Dr. Andrew Spires, Ms. Dawn Mason, and Dr. William Wetley, and we worked one-on-one with Dr. David Barker at Allegheny General, so without them this research wouldn't have been feasible. So I think those are references. Any questions?